there is an Alexander's law for nystagmus that I will be telling you in this module. There is another Alexander's law for life. And what is that Alexander's law? If you are given 1 month to do something, you will finish it in 1 month time. Whereas if the same thing you have to finish in 3 days, you will finish it in 3 days. Yes, you can try it, and you have to try it. Where? Every month you have to give grand test. There is no escape. Don't think that you will finish your whole course and in the end only you will give grand test. You have to give grand test from the beginning itself. So every month at least once you have to give in the beginning. Later on, during your first revision, you have to give every 15 days. And before every grand test, keep 2 days. 2 days for preparing till whatever you have done till now. Or maybe you can give 3 days also when the whatever you have done increases. So, and then you can just apply this and you can see that yes, it holds true. In 2 days, you will be able to quickly revise all that you have done, and that is what will be required from you just before the exam. So when you do it again and again, you exactly know how you have to revise it in a very short time. So apply it. It is true. We have divided the conditions of the inner ear into 3 modules, as we are already seeing that we have divided it into the conditions which can involve the whole of the inner ear, where the patients will present with cochlear as well as vestibular symptoms. That we just did in the last module. Then the conditions which can involve only the vestibular part, where the patient will present only with vertigo, and the conditions which can involve only the cochlear part, where the patient will only present with hearing loss, that is sensorineural. So in this module, what we will be doing will be the conditions of the inner ear which present only with vertigo. Which means if the patient has only vertigo in the question, there is only one thing, that is vertigo. Can you tell me before starting this module, can it be mean ears? Yes or no? Only vertigo, no hearing loss. Can it be mean ears? No. If there is only vertigo, no hearing loss, can that be a labyrinthitis? Yes or no? No. Can that be only vertigo, continuous vertigo for very long? Can that be a fistula or a third window? Yes or no? Continuous vertigo for very long? No, there it is only vertigo on loud sounds or on pressure changes. And there also there is associated hearing loss, conductive hearing loss in superior semicircular canal dehiscence. And it can be a mixed or a sensorineural hearing loss in fistula. Yes, so which means that if the patient is presenting only with vertigo, those things we are not going to think of. Is that very clear? So what are we going to think of when the patient complains only of vertigo? So what are the conditions of the inner ear where the patient presents only with vertigo, which involve only the vestibular part? So they are the 2 conditions. One is the benign paroxysmal positional vertigo and the other is vestibular neuritis. The name itself tells you vestibular neuritis. It involves only the vestibular nerve. It is an inflammation, acute inflammation of the vestibular nerve. So the most common cause of vertigo in the OPD is Bppv or benign paroxysmal positional vertigo. This is the most common cause of vertigo. And as the name, it is paroxysmal, so it happens in episodes, in paroxysms, positional vertigo on changing the head postures. So what exactly happens in Bppv? We already know, we have done it in vestibular physiology, but let us quickly have a look what happens here. So we have in the maculae of the utricle otolith, and this otolith can get dislodged. Why they can get dislodged? They can get dislodged because of head trauma. They can get dislodged because of infections. Many a times the exact cause is also not known. So ultimately what has happened is they have got dislodged. And then now they have become free floating. they can now enter any of the semicircular canal. Most commonly, they enter into the posterior semicircular canal. So most commonly, they go into the posterior semicircular canal because of its dependent nature. And the second most common is the horizontal semicircular canal. The superior semicircular canal is almost never involved because of its superior orientation, and also even if the otolith go there, they come back by themselves. Usually patients do not have otolith going into the superior semicircular canal. So these are the two semicircular canals, the posterior and the horizontal, which we are most likely to get patients of, and that is what is asked in your exam. So now what has happened is that this otolith has gone into the semicircular canal. Whenever that particular semicircular canal gets active, this otolith will move because of movement of the endolymph, and that will irritate that semicircular canal, leading to vertigo. Since this is calcium carbonate crystals, because of gravity, it will immediately settle down and the patient will be fine till he changes his posture of head again. So this is the typical history of Bppv, and you cannot mistake this question. Typically, always in the history is given when the patient turns his posture, when the patient turns his head to the right, when patient turns his head to the left, whatever. Typical history is given lasting for a few seconds. Yes, so all this history, when it is mentioned, we know that the diagnosis is Bppv. So here there is a typical history of vertigo lasting for a few seconds only on posture change. Only on posture change. So whenever such is the presentation that is given to us, now our aim is to confirm whether it is Bppv or not. And second, if it is Bppv, which semicircular canal is involved? Yes, because what will be the management is that we will have to bring back the otolith into the utricle by a repositioning maneuver. And this maneuver is different for different canal. So we have to know exactly in which semicircular canal the otolith has gone. How can we find that? Yes, we can find that by stimulating that particular semicircular canal. If the patient has a Bppv of the posterior semicircular canal of the right side, the moment we place the patient in this position, the otolith will move and stimulate the canal, and patient will have very severe vertigo. And this vertigo will also be associated with nystagmus. And the characteristics of nystagmus you need to know, and that is what is asked in your exam very commonly. Yes, the characteristic will be the typical features of a peripheral origin nystagmus. Will it have a latency? All this we have done in the vestibular physiology. Yes, you need to see the vestibular physiology module before you come to this module. So what will be the characteristics? Will there be latency? Yes, which means that the moment you make the patient lie down, you will see that the nystagmus starts after some time. So yes, latency is present of a few seconds. Few seconds latency is present. It can be 10 to 20 seconds latency. If it has gone into the vertical canals. What are the vertical canals? Posterior and anterior are vertical canals. They are aligned in the vertical plane, whereas horizontal semicircular canal is in the horizontal plane. So if it is a vertical canal, that is a posterior semicircular canal, Bppv, then it will be, the nystagmus will be a vertical nystagmus with torsion. Whereas if it is a horizontal canal Bppv, then it will be a horizontal nystagmus. We know the Evold's law. What is that? That the nystagmus is always in the plane of the canal stimulated. So horizontal canal will be horizontal nystagmus with torsion. So torsion will be present. Yes, torsion will be present. What will be the direction of nystagmus? Yes, we know that direction of nystagmus is always towards the more active side. So whichever is the hyperactive side, when we are stimulating the right semicircular canal, so this becomes the more active side. So if the patient has Bppv of right posterior semicircular canal, here the nystagmus will be towards the right. What is the meaning of direction of nystagmus? Direction of nystagmus means, is it the fast component or the slow component? Yes, direction of nystagmus is always the fast component. And as we remember it, that direction is always towards the more active side. If there is a destruction of labyrinth of one side, what becomes more active? the normal side. If it is a hyperactive labyrinth like in Bppv, then what becomes more active? The hyperactive side. So in this case, in this patient, if it is Bppv of right posterior semicircular canal, how will be the nystagmus? Yes, the nystagmus will be towards the right side. The fast component will be towards the right side, towards the lowermost tier. So yes, direction is the fast component. Fast component. And here it will be towards the hyperactive side. Towards the hyperactive, that is towards the involved ear here. Hyperactive side. And yes, it will be of limited duration. You make the patient lie down in that position only, you will see that nystagmus appears after some time and it disappears after some time. So yes, the duration is limited. It is limited from a few seconds to maximum 1 to 1.5 minutes. And is it fatigable? What's the meaning of fatigable? Yes, when you repeat the test, repeatability is not there. You do this test once, you will get the nystagmus. You're very happy. You called your junior also. See, nystagmus is there. You did again you get nystagmus. That person called his friend also. Come, see, there is nystagmus. Yes, see how this is positive. And you do again, no nystagmus. Yes, so it is fatigable. It is, the repeatability is not there. So fatigable, yes, it is fatigable. Yes, it is fatigable. So all these characteristics will be present in nystagmus of Bppv. So let us quickly see how the nystagmus of a posterior semicircular canal will appear. Before we see how nystagmus looks like, now yes, I know that most of you will be seeing nystagmus for the first time in this video. In fact, you will be seeing nystagmus for the first time in your life. So yes, when you see the nystagmus repeatedly again and again, only then you are actually able to make out the fast component. You are able to make out the direction of nystagmus. You are able to make out the torsion is there or not. So these videos, what I am focusing on is everything, but just try to notice the gross things. Whether you are able to notice what nystagmus it is, when you see repeatedly, you will be able to notice what the direction is and whether there is torsional component or not. So that next time when you go to your clinics, when you actually examine the patient, at least there is a nystagmus in the patient you should be able to identify. If that much you are able to identify, then the purpose is solved. Before you see the video for how a nystagmus of the peripheral and how a nystagmus of the central origin, how the nystagmus of Bppv or how nystagmus of vestibular neuritis, how they appear, yes, my dear students, I know that most of you would be seeing the nystagmus for the first time. So yes, just try to notice the gross things in the nystagmus, whether you are able to make out or not that there is a nystagmus. If possible, yes, what the direction of nystagmus is, so that when you go to the clinic, if you see any patient, at least if you are able to make out that there is a nystagmus, would be a wonderful thing. When you see it repeatedly again and again, it is only then that you actually can see and tell immediately, yes, that this is the direction of nystagmus. Yes, this is a nystagmus which is vertical, which is horizontal, or there is a torsion associated with that. So when you see this video also repeatedly, you will see that you are able to appreciate the things better. Yes, if you are expecting that you will see it once and you will know everything, that will be maybe expecting a little too much from yourself. So just see this video and try to appreciate the gross things. Later on, when you see it repeatedly again and again, yes, you will be exactly, the moment you see the nystagmus, you will be able to say that this is this direction nystagmus, this is a horizontal or vertical nystagmus, it is associated with torsion or not. So yes, let us now have a look. This is a patient who has come with a history of vertigo whenever she turns towards the left. And yes, it is a very episodic vertigo lasting for a very few seconds. And this typical history is very much suggestive of a positional vertigo, that is Bppv. So we are going to test her first for Bppv and For testing for Bppv, yes, the most common canal involved is the posterior semicircular canal. The typical history that she is giving is all towards the left side, so that is being tested here first. Definitely, if the patient does not give such a history, we have to test of both the sides. Even if she is giving such a history, it is always better to test both the sides. In this patient, what is being shown to you is the left canal being tested. Yes, can you make out? Can you see and tell that the head of the patient is turned towards her which side? Towards her left. So we are testing her which ear? Yes, we are activating her left canal, her left ear, and we will place her in the position of activation of the left posterior semicircular canal. If in her left posterior semicircular canal there is otolith, when that semicircular canal gets activated in that particular position, otolith will move, irritate the semicircular canal, and that will lead to very severe vertigo in the patient. Along with that, what we will be able to see is the nystagmus. So in this patient, the nystagmus will have all the characteristics of the peripheral nystagmus. Yes, what are they? Before we start, I will like to tell you so that you can focus on these things. The nystagmus will have a latency, which means the moment you make the patient lie down, the nystagmus will start after a few seconds. The nystagmus will disappear after some time. Since it is because of posterior semicircular canal, so posterior semicircular canal is a vertical canal, so the nystagmus will be vertical and it will have a torsional component. The direction of nystagmus will be towards which is the hyperactive ear, that is here we are testing the left posterior semicircular canal, so it will be towards that ear. Yes, so let us now start and let us see how the nystagmus will appear. So now we are starting the Dix-Hallpike test. We are testing a left posterior semicircular canal. No nystagmus. Yes, now the nystagmus has started. So it had a very short latency of a few seconds. We are seeing it is a vertical nystagmus with a torsion, and you can see that the torsion is towards the fast component was towards the left ear. Now the nystagmus has disappeared. The nystagmus will be in both the eyes, it will be same. Here the right eye is being shown to you so that you can see it clearly in one eye. It does not mean it is in only this eye. See the vertical component which has a torsion, and yes, it is towards the downmost ear, towards the ear which is in the dependent, which is activated, that is towards the left ear. And the torsion is also towards the fast component. The fast component is the direction of the nystagmus. And now we can see that the nystagmus has disappeared. So yes, all these are the characteristics of the peripheral nystagmus. Another patient, again the left posterior semicircular canal is being tested. We can see no nystagmus as of now. Yes, it has started, so it had a latency. And yes, again, it is a vertical nystagmus because of involvement of the posterior semicircular canal. See, in both the eyes, the same movement, the conjugate movement. Nystagmus is seen, both the eyes same. It is a vertical nystagmus. Now it has disappeared. Now you will be able to see a closer look in, yes. So here we are seeing a vertical nystagmus. The fast component is the direction of nystagmus. Here again, it is towards the left ear. That is the ear that we are testing. That is the posterior semicircular canal that has got stimulated. So the nystagmus is towards the ear which faces the ground. That is the one that we always stimulate. To stimulate it, we have to place it towards the ground. So now we are seeing that it has slowed down, and yes, it will disappear. So if the patient who has come to you with a complaint of episodic vertigo lasting for a few seconds on posture change, and all this history which is suggestive of Bppv, the next step is to do a Dix-Hallpike maneuver to rule out a posterior canal Bppv. If it is negative, then we go for a supine roll test. That is to rule out a horizontal canal Bppv, which is the next most canal to be involved. So if the Hallpike test is positive, so then we go for repositioning, bringing back the otolith back into the utricle from the semicircular canal, and this maneuver is what is known as Bppv maneuver. This is Epley's maneuver and this is done for posterior canal Bppv. And let us quickly see how this is done. And yes, just a 5-minute procedure, a series of 5 different positions you place the patient in and patient will be perfectly fine. And this costs the patient a minimum at least 3,000 rupees in the OPD, just a 5 minutes procedure, which means, yes, you should learn it. Yes, learn it. And believe me, so many of you send me messages that my uncle had this, my friend had this, and we reverted it back to the normal, and we were praised so much that we are becoming very nice doctors. Yes, so this is something, as I told you, is the most common cause of vertigo in the OPD. Bppv. So you should know how to diagnose it. You should know how to manage it. So let us quickly see how a Epley's maneuver is done. Let us see how the Epley's maneuver is done. Now, before you do the Epley's maneuver, you have to be very clear in your mind which ear and which semicircular canal of the patient is involved. And that you do by a Dix-Hallpike maneuver. In this patient, where the demonstration is being done, the left posterior semicircular canal is the involved one. If it is the right posterior semicircular canal that is involved, then you will start this procedure from the right side. The head of the patient is turned towards the left 45 degrees and now the patient is made to lie down. The head is extended 10 to 20 degrees again towards the affected side. Now the head is turned towards the unaffected side. And now the patient is made to roll the body towards the unaffected side and the head is further rotated 90 degrees till the face faces the ground. And then the patient is made to sit upright and the head is flexed 20 to 30 degrees forward. Now in this video, what was shown to you was all the positions were in quick succession. But when you are actually doing the Epley's maneuver, the patient's head has to be placed in the particular position, in whichever position the head is placed, for at least 30 to 40 seconds till the vertigo and the nystagmus disappears. If it is a Bppv of the right posterior semicircular canal, then you will start from the right side and then you will proceed accordingly. That is how the Epley's maneuver is done. If the Hallpike test is negative, Dix-Hallpike test is negative, it means it is not of the posterior semicircular canal, then we have to rule out a horizontal canal Bppv. For that, we do the supine roll test. So let us quickly see how the supine roll test is done and how, if it is horizontal canal Bppv, it will show as positive. So in this patient where the Dix-Hallpike test was negative, a supine roll test is being done to rule out a horizontal canal Bppv. So to test the horizontal canal, we know that we will have to place the head of the patient in the plane of the horizontal canal. That is, we will have to turn the head horizontally to the right to test the right ear and to the left to test the left ear. And if there is otolith in the horizontal semicircular canal, what will be the type of nystagmus? Yes, it will be a horizontal nystagmus with torsion, and the direction will be the fast component, and the fast component or the direction will be towards the hyperactive, that is towards the more active ear, the ear that is involved. Yes, so now in this patient, we are turning the head horizontally to the right. So if there is otolith in the right horizontal semicircular canal, we will see a horizontal nystagmus. Yes, so let us see this patient. Yes, so we have turned the head to the right, initially known as nystagmus. Now we can see a horizontal nystagmus with torsion. So yes, again here we are testing the horizontal semicircular canal, horizontal plane, no nystagmus initially, so there is a latency. Now you can see a horizontal nystagmus signifying that there is involvement of horizontal semicircular canal, and yes, it has disappeared. So it has all the characteristics of the involvement of the peripheral horizontal semicircular canal, and now according to which semicircular canal it is, whether the Dix-Hallpike is positive or the supine roll test is positive, we can go for the management of the patient. So if the test is positive for a horizontal canal Bppv, then we have to revert it by a different maneuver. The maneuver here will not be a place maneuver. Here the maneuver that we do is a barbecue roll maneuver or a Guffoni maneuver. If you just know the names of these two is sufficient. Now, once you have reverted it, yes, believe me, the patient will be so thankful to you. This is something where the patients are so scared, they become vertiginous. The vertigo is so severe for a few seconds. Even if it is for a few seconds, it is so severe that they feel so debilitated that they do not know which posture is leading to it, but they know that they will get it, and whenever they will move their head, and they are very debilitated, and they came to the OPD, you have diagnosed it very correctly and you have treated it so beautifully, and they feel as if you are a magician. You did not do anything, just you made the patient lie in a series of 5 different positions and the patient is perfect. Yes. So all of you have to tell the patient whenever you treat the patient that this can recur. Yes, the wonderful thing about this is that you can revert it back to normal immediately. But yes, this can recur again. So chances of recurrence are there because this is because of free floating otolith. So yes, recurrence is positive. So now quickly tell me, which is the most common semicircular canal to be involved in Bppv? Posterior semicircular canal. What is the most common cause of vertigo in the OPD? Yes, Bppv. Which is the next most common canal after posterior semicircular canal? Horizontal canal. How do you test the horizontal canal Bppv? Which test? Supine roll. For posterior canal Bppv, what is the test? Dix-Hallpike. What is the management of a posterior canal Bppv? Which maneuver? A-place maneuver. For horizontal canal, what do we do? Yes, we go for Guffoni maneuver or barbecue roll. A nystagmus of peripheral origin or because of posterior semicircular canal will be vertical or horizontal? Vertical. With torsion or pure vertical? Yes, with torsion. Pure vertical, pure horizontal and pure torsional nystagmus is seen only in a central involvement. Because of inner ear, whenever there is nystagmus, because of inner ear involvement, it will always be a vertical with torsion or horizontal with the torsion. The direction of nystagmus will be towards, yes, the hyperactive side. That is the involved side here.